Hello, this is Dr. Gregory Jenkins calling from downtown Newhall. We are the Doc and Doc Show, and we're on AM 1220 KHTS. If you have any phone calls, have any questions you want to ask one of the two doctors, today one of the three doctors here, just dial us at 298-5487. Today we have a guest with us who's Dr. Mark Cinder. He's a board-certified urologist practicing in Valencia. And he's also in the past been at UCLA and did transplant surgery, and his list of achievements are quite long. But today we asked him to come on our show with Dr. Curts and tell us about urology and how that can affect you. So I want to introduce Dr. Cinder. Do you have anything to talk about yourself, sir?
Well, thank you for having me, Greg and Judith. And what I'd like to do is perhaps discuss a few aspects of urology that the public probably doesn't spend that much time thinking about. The first one I'd like to talk about has to do with how incontinence, that is the leakage of urine, affects people. And I think there's a lot to be said about that, and it's a subject that is little covered in the public. It's little covered in many offices because many people don't ask about it.
Isn't it an embarrassing thing for people sometimes? You know, a woman sneezes and she leaks a little bit, and she really, how do we give her some comfort to come to you?
Well, that's the point that I wanted to make, that it's something that can be treated. It's something that does require some analysis and testing to understand, but once again, we have things to offer. Many times, the patient assumes, well, I'm getting older, they've had a couple of kids, and they think, well, it's just a consequence of that, and there's nothing we can do to get it better. But it turns out there are a variety of things that can contribute to the leakage problems, and we can certainly treat them. We can assess them and treat them appropriately. And if you'd like, I'll go over the basic categories. There's essentially two major kinds of incontinence. There is the kind of incontinence that you alluded to, such as the coughing, sneezing, laughing, getting up from the chair, and that's considered stress incontinence because there's some stress that's caused that allows the urine to pass because the support for the tube that carries urine out of the bladder, that's the urethra, is poor. And that requires some assessment to determine just how bad that is. And many times it can be treated with simple behavioral modification sorts of things, such as exercises, Kegel exercises. It's also being aware that at a certain volume of the bladder, when they cough, the person may leak, so to try to urinate more frequently. Perhaps drink less fluids, although we certainly don't want to do that in Valencia this weekend where it'll be 105 degrees.
Oh, that's right. It's heat waves. The heat waves here.
The heat waves
this
coming.
studio ought to be burning up by then.
But the main thing is that it can be analyzed and assessed, and stress incontinence is probably the most common kind of incontinence that we encounter. The other kind of incontinence is called urgency incontinence. As it sounds, urgency just hits the patient like they really got to go now and they can't hold it and they may leak. That may be anticipated years before with the simple urge to void many, many times, more frequency, getting up more at night, things of that nature. But that's a separate kind of problem that is not as much an anatomical or surgical problem. And that usually requires medication or some sorts of treatments, which I can go into as the discussion allows.
Perfect.
I would love to hear that.
That'd be great.
Okay, so let's go over the assessment. Someone comes into the office because they've gotten over the hurdle of being too embarrassed to mention it to their doctor and to be referred, or they come in of their own volition. And they say, well, I'm leaking. So the first question is, well, under what circumstances do you leak? Is it when you get up from the chair, or is it when you sneeze, or when you laugh? Or surprisingly, so many women say when they're jumping on the trampoline, which I'm incredulous, but it happens time and time again.
Wow.
Anyway, there's that sort of incontinence, and the alternative, as I said, is a kind of incontinence that can occur simply because the bladder got full and they can't make it to the bathroom in time. Sometimes we hear about, oh, the water's running and they begin leaking. Many times men complain of it that way, because this is not a problem that's limited only to women, by the way. Men have it too, and it may be an ego that doesn't permit the guy to show up, but they should do it as well, because there's many things we can do to help them. Be that as it may, the first thing is always to try to do some behavioral modifications, something that is a lifestyle issue. It may be they're drinking too much fluids. It may be that they have to learn how to do these exercises to do some kind of guarding. Let's say that doesn't work, and most of the time it really doesn't by the time I've seen the patient. Then the next thing we do is, if they have this urgency, this need to go, we try medications. It turns out that there's essentially 3 reasons why somebody would have urgency to go, urgency incontinence. The first and most common, fairly simply, is the inner lining of the bladder may be inflamed, and that can occur certainly with, most commonly, a urinary tract infection, let's say a bladder infection. And clearly, the first thing you do with that is look at the urine, assess if there's an infection or not, and give them the appropriate antimicrobial. Presumably, that's going to cure the infection, then their symptoms should go away. If that doesn't work, then the next possible cause has to do with the bladder wall itself. The bladder wall is made up of muscle that allows it to contract, elastic tissue that allows it to stretch, various amounts of fibrous tissue that allows it to have a certain shape. Additionally, in the wall of the bladder are little receptors that send information back to the brain as to how full the bladder is. In other words, when the bladder is empty, they shouldn't be firing. As the bladder fills more and more, the information should be related back to the brain that, yeah, it's getting fuller and fuller and fuller. And eventually, as most of us all know, when you're really, really full, you have to go desperately. So that would be the typical expected way that these receptors work. However, there are conditions in which the receptors start firing when the bladder's almost empty, and you still got to go because your brain's telling you have to urinate. So therefore, you need to go to the toilet, or you might leak. We have medicines to treat these receptor type issues too, and there's a variety of different kinds. And typically, just by history, we can get enough information to allow us to discern what kind of incontinence there may be. The third kind of factor that can affect the voiding function and the urgency to go has to do with nerves that go to the bladder. Obviously, nerves start in the brain. Nerves travel down the spinal column, and at every level of the body, they go to what's appropriate. And to get to the bladder, the nerves travel from the back in the spine anteriorly, that is forward in the pelvis, to get to the bladder. If there's something that somehow tweaks the nerve or does something to the nerve that makes it fire inappropriately, you're probably going to have to go urgently or frequently. And whereas we don't have any medicines to treat a nerve, I mean, think about it. If the nerve's overactive, you probably want to give it something to calm it down, but any pill you give or any medication you give is not going to know that it only wants to treat the bladder nerve and not the nerves to the, muscles to the arms or GI or tract or whatever. So we don't have any pills for that. However, we do have ways of treating the nerves. Now, that isn't the first thing we do, is treat the nerve. The first thing we would do is try to treat some of those other things, such as the bladder wall issue. And that's medication, which is very, very successful in most patients. And that's sort of what I want to relate, that we have ways of treating this problem that is fairly simple. The patients have to be willing to accept the fact that it may take a little bit of experimentation to get to the point where they do indeed have good control. And if the medications don't work, there are more things we can do. So the patient really shouldn't give up. They shouldn't just assume, I got a problem, I'm gonna have to live with it. They can be happy and deal with it that way.
So there is hope.
There's
for
absolutely
this.
hope, yes.
It's not, I'm too old, it's over, I'm just going to have to wear Depends and that's it, huh?
Absolutely.
That's great. I'm excited that you're here, and we've been looking forward to you being a guest on our
Thank you.
show. There are a couple of things as a sexologist that I'm interested in, of course, the ED medication, and for women that I treat, how do you keep a healthy vagina? I mean, how do you keep it healthy? You hear all these things about should you douche, should you not? I have my own opinion on that. And the one thing that I've always heard, and you can answer this, is before and after sex, empty your bladder. Okay, so you're hot and heavy with somebody and you say, oh, excuse me, I've got to get up and go. You know, that's just taking care of yourself. It's not embarrassing. Everybody goes to the bathroom, but is that a good idea? Is that good advice? Or not?
Well, okay, let me go through these things one thing at a time. Let me address the urination, the women urinating before and after intercourse. The reason why a woman is liable to get a urinary tract infection after intercourse has to do with the fact that there is normally and naturally bacteria in the vaginal region. With the increased lubrication and a bit of trauma, the urethra may allow the bacteria to travel back into the bladder. And if there's urine present, bacteria like to grow in urine, and certainly all of us has had the experience of walking into a restroom that smelled really bad. Well, that's because urine splattered and the place wasn't cleared adequately and it smells bad, and that's bacteria growing in the urine. So essentially the same thing is going on in the woman's urinary tract. However, if the urine is now evacuated completely, the bacteria are no longer in the bladder, there won't be an infection. In those women who can't empty completely, and there's certainly women who at times can't, we can give an antimicrobial, that's an antibiotic, after intercourse, which will sterilize the urine. We're not treating a urinary tract infection, we're simply treating the notion that they may get an infection and try to avoid it simply by doing that. So that's a common thing that we offer. Addressing the issue of whether to douche or not, if the vaginal lining is adequately estrogenized, that is, there's enough estrogen around that the tissue is healthy, it's probably not necessary to do a douche. And in addition, if there's poor estrogenization, that is, there isn't enough of the female hormone around, then if you do a douche, you may traumatize the tissue, and that makes a situation where there may be more bacteria present, or more bacteria that is pathogenic, that is capable of creating an infection, and that might be more of a problem than it's worth.
Well, I'd like to make sure that our listeners understand what estrogenized is.
Oh yeah, let me go over that.
And I think Dr. Sender can tell us exactly.
Okay, there are hormones. Men have testosterone, as you probably know. Women have estrogen. Those are that's the predominant sex hormone that each gender has. And estrogen has the ability to make the vaginal tissues, among other tissues, healthy if it's present. When a woman hits menopause, the amount of this estrogen, the female hormone, is depleted, and those tissues which normally expect the hormone to be around are no longer able to stay as vigorous as they should normally be, and therefore they're less able to do their job, the job being fighting the bacteria that may be capable of causing an infection, say.
Okay, that's helpful.
You know, it's really nice here. We always invite you all into our offices. So you've got an internist, you've got a certified sex therapist, and now you have a urologist, and you are invited into these offices that are on air right now, or email us a question. The number is 661-298-5487. 298-5487. If you have any urology questions, I mean, when do you go to a urologist? When instead of going to your primary doctor, when do you make that decision?
That's a good question, and sometimes I ask it myself because some people come in and they probably should be seen by their internist. But suffice it to say, any problem that is self-identified in the urinary tract deserves a urological evaluation. There are such things as kidney stones, which are obviously, you may have heard, can be very, very painful as one is trying to pass a stone. One might go to the internist first to have that assessed and then be sent to the urologist, but someone who's maybe had more than one stone and recognizes that it feels like what I had before, they should probably go either to their urologist or to, say, the emergency room if the pain's so severe. Other things that are within the province of the urologist have to do with anything dealing with the kidneys, the ureter, the bladder, or the genitalia. So it's a situation in which the individual patient needs to feel comfortable with the doctor they go to. If they feel comfortable going to their internist, their primary care doctor, many, many things can be handled by him or her. And I'd really recommend that first. And to make an appointment for a urologist can best be done by seeing their primary doctor, who then can assess properly. And that's the appropriate use of health care in the nation. To sort of digress a little bit, we're getting an aging of the population, and people maybe realize that urologists tend to deal with more elderly patients, and we're going to have a deficit in the number of urologists that are going to be available to the public. It turns out that up to 30% of urologists are going to be retiring in the next 10 years just because the natural attrition rate. And the population is not going to go down during that period of time. So it's going to be a matter of getting physician extenders as well as the urologists themselves. Urology is actually both a medical and a surgical specialty. And in time, it will probably be almost more a surgical specialty reserved for those difficult surgical problems that urologists can attend to, as opposed to dealing with the medical aspects of it, such as, like I was referring to, dealing with the overactive bladders with medications. It's true, the workup is within the province of the urologist, but one of their own volition, unless you self-identify and say, I know that I've got this problem and my internist isn't comfortable dealing with it, I'll go see the urologist. That would be fine. But I still advocate going to see people like Dr. Jenkins or your own internist or family practitioner. That's probably the best move. And don't be afraid to do that. That's important. They can help you. They can direct you. They know what to do.
Are people coming to you, and I know we're going to have to go to break soon, but I want to talk about ED medications too, because I think so many people, perhaps the millennials that are so with the internet, that they're getting things on the internet that may or may not work. So stay with us because we have some great stuff to talk about. And this is KHTS 1220, 661-298-5487, your hometown station.